My name is Dr. Lenore Powell, and I am a medical education specialist here at Genova, and I will be reviewing the Organix profile. For this presentation, we will cover important core concepts as it relates to nutrition testing, especially organic acids. We'll also review a sample report and cover the individual markers, and lastly, review available resources. Organic acids are compounds produced by the body in numerous body systems, and we measure these metabolic byproducts or end products to better understand nutrient deficiencies. It's kind of like a virtual biopsy of the human metabolome where we're just searching for metabolic dysfunction, and based on the result, it provides indications of needs for vitamin and mineral cofactors required to drive the pathways. So here in this example, we see a basic pathway where A converts into B and into C, which is the end product. The enzyme that facilitates converting A into B is E1, and the E2 facilitates B conversion into C. So each enzyme is supported by certain nutrients. If the nutrients or cofactors for the enzymes are deficient, like here for E2, it's going to cause a backup, and we will see an accumulation of B in urine. So measuring organic acids and knowing which enzyme is involved in a particular pathway allows us to understand your unique need for a particular nutrient. Now, it is possible for an individual to have normal blood levels of vitamin in order to maintain homeostasis while actually exhibiting signs of insufficiency or deficiency for that vitamin. And for this reason, direct testing of individual nutrients alone does not provide a complete picture. Now, whether you should stop or continue supplements prior to testing depends on if you want to understand baseline need for nutrients, in which you would have the patient discontinue their supplements. But if you are interested in how effective your supplement regimen is, then have that patient continue their supplements. I get this question quite often. What are the clinical indications for ordering a nutrition evaluation for my patients? And here is a list, although not exhaustive. The top 3 reasons I see clinicians ordering this profile are mood disorders, fatigue, and optimization of patients' health or athletic performance. Here's the big picture of what's measured. We will cover all of these as we work our way through the sample report. The Organix profile. So the front page is a synthesis of clinically actionable information. The next page provides customized nutrient recommendations based on the results of the profile. And my favorite section for the patient education is actually the interpretation at a glance, providing greater information about each nutrient, including food sources, that is assessed on the report. Followed by the citric acid cycle, or our body's ATP production that occurs within our mitochondria. The biomarkers page listing the organic acids grouped into functional categories. And lastly, oxalate and oxidative stress markers. Before we dive into clinical interpretation of the organic acids, please become familiar with our Organic Support Guide that is available on our website. It is an extensive guide that is fully referenced, and if you are a visual learner like myself and enjoy looking at pathways, you will find this resource very valuable. So the front page of the report is a synthesis of information based on the results of the test. Here we basically transform the patient's test results based on 2 factors. First, it takes into account how abnormal the biomarker is or the severity. The other contributing factor is based on the strength of evidence for that biomarker. And this gives you an overall understanding of varying dysfunctions in the area of mitochondrial dysfunction, toxic exposure, and methylation imbalances. The overall dysfunction for the pillars is scored. A green score of 0 to 4 indicates that there is minimal need for support in that area. A yellow score of 5 to 7 indicates a need for moderate support, and a score of 8 to 10 indicates a need for high support, which will show up as red. For this sample report, mitochondrial dysfunction and toxic exposure have a functional score of 8, or high need for support, and the methylation imbalance has a score of a 7, or moderate need for support. Many of the nutrients that support these categories are listed on the next page of the report. The nutrient recommendations on the following page are intended to support these 3 main categories on the first page of the report. You will see recommendations for antioxidants, B vitamins, minerals, and GI support, or basically the need for digestion, absorption, or microorganism support. Although you see recommendations for nutrients, please feel free to modify the recommendations based on your patient's clinical presentation. Pages 3 through 6 are the interpretation at a glance pages that provide additional information about each nutrient recommendation. As with all the scores on the test, the higher the score, the greater the need for support. The first bullet point lists the functions of the nutrient. The second bullet point lists causes of deficiency. The third bullet point discusses symptoms of deficiency. And the fourth bullet point lists food sources for that nutrient. These pages can be helpful for identifying why a patient might have a higher nutrient need. The citric acid cycle pictured here provides a nice illustration of functional need for nutrients. The patient's results are highlighted in either green, yellow, or red, depending on whether the analyte is normal, borderline, or abnormal. And this allows you to visualize whether there are backups in cellular metabolism and where the trouble spots might actually be. At the top of the page, we see how the micronutrients, fats, carbs, and proteins ultimately turn into energy for the cell in the form of ATP. Fatty acid metabolism. Dietary fats are metabolized into fuel, or ATP, using beta oxidation. The conversion into acetyl-CoA requires these fatty acids to move across the mitochondrial membrane via the carnitine shuttle, with B2 and magnesium as cofactors. When beta oxidation is impaired, fats are metabolized using an alternate pathway called delta oxidation, which results in elevated levels of adipic acid and/or subearic acid. Pyruvic acid and lactic acid are byproducts of glycolysis. Carbohydrates, which contain glucose, are broken down through glycolysis to form pyruvate and 2 ATP molecules. So you can also make pyruvate from breaking down various amino acids. You see in the diagram that magnesium is an important cofactor in this process. Ideally, pyruvate is oxidized to form acetyl-CoA by the pyruvate dehydrogenase complex to be used aerobically via the citric acid cycle to produce energy. In an anaerobic state, lactic acid is formed instead. So with an elevation in pyruvate, we need to support the pyruvate dehydrogenase complex with the listed cofactors B1, B2, B3, B5, and alpha lipoic acid. This enzyme is sensitive to certain toxins like antimony, mercury, and cadmium, which can also lead to an elevation in pyruvic acid. Again, lactic acid is produced in an anaerobic state, such as pulmonary disease, anemia, sleep apnea, even as a result of strenuous exercise, insulin resistance, and alcohol dependence. Zinc is an important cofactor that regulates the lactate dehydrogenase enzyme to help its conversion back into pyruvate. Beta-hydroxybutyric acid is a ketone body. During periods of fasting, exercise, and metabolic disease, ketones are generated in the liver and become basically an energy source instead of using glucose. And high levels are also seen with low carbohydrate intake. The citric acid cycle's goal is to metabolize or create energy from our diet or macronutrients. So a series of enzymes and cofactors really makes this happen. Here is a great reference to review. So both citric acid and cis-aconitic acid use the aconitase enzyme supported by iron and antioxidants like glutathione. Isocitric acid is converted into alpha-ketoglutarate acid through the isocitrate dehydrogenase enzyme supported by B3, magnesium, and manganese. Alpha-ketoglutarate acid converts into succinic acid through a complex of enzymes we collectively call the electron transport chain supported by magnesium, B1, B2, and B3. Succinic acid uses the succinyl-CoA synthetase enzyme supported by iron and B2 to convert into fumaric acid, which is a hydration step, into malic acid. And malic acid converts into oxaloacetic acid using the malate dehydrogenase enzyme and supported by vitamin B3. And then the process begins again. You'll also notice in the diagram that heavy metals like fluoride, arsenic, mercury, antimony, and aluminum can inhibit or slow certain enzymes. So our environmental exposures also plays a role into ATP production. The electron transport chain is the most productive part of the cellular respiration because it yields about 30 molecules of ATP as compared to only 2 molecules produced via each glycolysis and the citric acid cycle. So it consists of a series of enzyme complexes in which electrons are basically transferred from one molecule to the next, and it leads to free radical production and the need for antioxidant support. Therefore, it's important to assess the balance of free radical production versus the availability of antioxidants. And although we do not directly measure CoQ10 or glutathione, there are specific organic acids that provides a functional assessment, which we will review in just a moment. The compounds of bacterial and yeast origin are byproducts of bacterial and fungal activity in the GI tract, and many of these bacterial metabolites can result from the fermentation of dietary phenols and flavonoids as well. Therefore, in the absence of dysbiosis, high levels of these phenolic metabolites can reflect a healthy intake of antioxidant-rich foods. When these markers are elevated as a group for overall trends rather than individually, a stool test may provide further information regarding dysbiosis or other GI dysfunction. Phenylacetic acid, or PAA, is produced from bacterial metabolism of phenylalanine, and N-acetic acid, or IAA, is produced from bacterial metabolism of tryptophan. Therefore, with an elevation, it could suggest incomplete digestion or absorption of either phenylalanine or tryptophan, or bacteria dysbiosis. In addition, dietary polyphenols may contribute to an elevation. DHPPA is a byproduct of the fermentation of dietary phenols by several bacteria, including some Clostridia species and several other bacterial species. So elevated DHPPA levels may reflect dietary intake of polyphenols or suggest dysbiosis or bacteria overgrowth. Again, this can be further evaluated through a stool profile. 3-hydroxyphenylacetic acid and 4-hydroxyphenylacetic acid. So amino acids that are not digested and absorbed can be metabolized by bacteria in the gut to form these organic acids. So an elevation can actually reflect malabsorption or dysbiosis. However, dietary polyphenol intake like tea, wine, grape, seed extract can also contribute to elevated levels. Benzoic acid and hippuric acid are formed from the bacterial metabolism of polyphenols. Therefore, elevations may suggest bacteria dysbiosis or dietary polyphenol intake. For the yeast fungal dysbiosis markers, we have diarabinitol, which is a sugar alcohol produced specifically by Candida species. Therefore, it is a useful marker for a diagnosis of candidiasis, especially if the patient presents with yeast-related symptoms, so like foggy thinking, skin rashes, fatigue, etc. The citramalic acid and tartaric acid are yeast metabolites that are also influenced by dietary intake of fruits, wine, and sugar as well. The cellular energy and mitochondrial markers, we already reviewed them on the prior page of the report, but there are 2 additional carbohydrate markers that we have not yet discussed. So alpha hydroxybutyric acid is the first one. So this marker relates to oxidative stress, and elevations are seen with the increased demand for glutathione, oxidative stress, insulin resistance, and as a result of hard exercise. As with any oxidative stress marker, antioxidants are helpful at addressing elevations, but also exploring the root cause can decrease the oxidative stress source in the first place. The second additional marker is beta-hydroxy beta-methylglutaric acid, or HMG, which is the precursor to cholesterol and CoQ10 synthesis. So it is a product of hydroxymethylglutaryl-CoA, or HMG-CoA. It's the rate limiting in cholesterol production. So CoQ10 is important for cellular energy production in the mitochondrial respiratory chain, and an elevation indicates the need for additional support. Vitamin markers. Alpha-ketoadipic acid formed from lysine and tryptophan. The cofactors in this step are B1 alpha-lipoic acid as well as B2. The next 3 B-complex vitamin markers are branched chain catabolites originating from your branched chain amino acids. Alpha-keto isovaleric acid is from valine, alpha-keto isocaproic acid is from leucine, and alpha-keto beta-methylvaleric acid is from isoleucine. So elevations may reflect dysfunction with the branched chain alpha-keto acid dehydrogenase enzyme due to nutritional cofactor needs, and that includes things like B1, 2, 3, 5, as well as alpha-lipoic acid. So elevations have also been associated with insulin resistance as a result of decreased breakdown for energy production. Glutaric acid is formed from lysine and tryptophan, requiring vitamin B2 to support the enzyme glutaryl-CoA dehydrogenase. Isofluroglycine produced from leucine breakdown through an enzyme acyl-CoA dehydrogenase that also requires vitamin B2 as the cofactor. This enzyme is not only involved in branched chain metabolism, but also beta oxidation of your fatty acids. For the methylation markers, we have the familiar methylmalonic acid, which is formed from certain amino acids and converted into succinyl-CoA to feed into the citric acid cycle by methylmalonyl-CoA mutase. This enzyme is B12 dependent, so whether the client's diet is deficient in B12, like we see with a strict vegan, or deficiency is due to medication or digestive issues, an elevation indicates the need for B12. Urinary methylmalonic acid does actually correlate with serum methylmalonate. FIGLU, or forminoglutamic acid, is an intermediate in the conversion of histidine to glutamic acid, and it requires B9-THF tetrahydrofolate as a cofactor. For the biotin markers, 3-hydroxypropanoic acid is a urinary metabolite of propionate, which is derived from dietary branched chain amino acids, odd chain fatty acids, as well as it can be produced by gut bacteria fermentation of fiber, and it's a biotin-dependent enzyme. A reduction in this enzyme's activity can lead to an elevation in this marker, which again can be due to a functional need for biotin or vitamin B7. 3-hydroxyisovaleric acid is formed from leucine, a branched chain amino acid, and the enzyme is biotin dependent, so whether you have a biotin deficiency due to diet or certain medications that accelerates biotin metabolism, like anticonvulsant medications or smoking, an elevation in this marker indicates the need for biotin or vitamin B7. For the neurotransmitter metabolism markers, these are your downstream metabolites of neurotransmitter synthesis and breakdown. So elevations in these organic acids can represent altered neurotransmitter metabolism, potentially due to enzymatic nutrient cofactor need or genetic predispositions, toxins, chronic illness, and stress also influence these results. The chironic acid and quinolinic acid are tryptophan metabolites formed from the chironine pathway, and tryptophan is the amino acid precursor. The historical importance of this pathway has mainly been as a source of the coenzyme NAD, which is important for all redox reactions in the mitochondria. However, it is now understood that chironate and quinolate pathway is upregulated in response to inflammation and stress, which can lead to deficient serotonin production. Quinolinic acid in and of itself can be inflammatory and neurotoxic. This pathway is particularly sensitive to vitamin B6 deficiency. B2 and B3 are also important cofactors. Oral hormone therapy can also increase quinolinic acid. This ratio, chironate to quinolinic ratio, is reported to see if tryptophan is catabolized via the chironine pathway rather than the serotonin pathway, which is associated in literature with, again, neurotoxicity, also major depressive disorder, as well as immune suppression, cancer, and inflammatory conditions. Xanthorrhinic acid is produced as part of the chironine pathway of tryptophan catabolism, along with chironic and quinolinic acid. Elevations of xanthorrhinic acid can reflect a functional need for vitamin B6, but also seen with tryptophan supplementation, oral hormones, as well as pregnancy. The serotonin marker we measure is 5-hydroxyendolycetic acid, or 5-HIAA, and it's a downstream metabolite of serotonin, which is formed from the essential amino acid tryptophan. So elevations as well as low levels of urinary 5-HIAA can reflect underlying intestinal microbial imbalances. Elevations are seen with medications that impact serotonin like SSRIs and 5-HTP, as well as diets rich in tryptophan like bananas, kiwi, and nuts. Cholamine markers. So homophenolic acid is the metabolite of dopamine, which is an important brain neurotransmitter, and a substantial amount is produced actually in the GI tract, but it's also derived from phenylalanine that converts into tyrosine. So elevations can be seen with a lack of vitamin cofactors to convert dopamine into norepinephrine, which are vitamin C and copper. Also, dietary flavonoids such as tomatoes and quercetin supplementation can elevate homophenolate. Norepinephrine and epinephrine metabolize into venomadelic acid and 3-methyl-4-hydroxyphenylglycol, or MHPG, depending on the resources available to support these enzymes. For VMA, when low, it could be amino acid or precursor deficiency of tyrosine created from phenylalanine. But when elevated, we think about medication influence, plus it correlates with the physiologic stress response, exercise, as well as PTSD. MHPG also is derived from the amino acid phenylalanine that converts into tyrosine and is the byproduct of norepinephrine and epinephrine. It's converted using the ADH, or alcohol dehydrogenase enzyme, which is supported by zinc and B3. These urinary markers can reflect exposure to environmental toxins or upregulation of detoxification pathways in response to exposure. So when these markers are elevated, the recommendation is to identify, minimize, and remove exposures. Let's also consider the use of antioxidants and nutritional support of detoxification pathways to help with clearance and protection of the cells from oxidative damage. Pyroglutamic acid is produced and used in the gamma-glutamyl cycle that assists in the production and recycling of glutathione back into the reduced state. So elevations can be due to increased use or need for glutathione in response to oxidative stress, and low levels can be seen in states of low oxidative stress or when we lack the building blocks or cofactors to build it. So with elevations or deficiencies of this marker, we consider glutathione support with amino acid building blocks, glutamine, glycine, and cysteine, as well as recycling cofactors, vitamin C, magnesium, alpha-lipoic acid, and selenium. Alpha-ketophenylacetic acid is a urinary metabolite of styrene, toluene, xylene, and ethylbenzene. And these chemicals are commonly used in the synthesis of polymers like plastics, rubbers, and surface coatings, but also in paints, pigments, glues, unleaded gas. Clinically, it actually can interfere with the peripheral conversion of your thyroid hormone, and it also affects the capacity to repair DNA. Clinical associations with an elevation in alpha-ketophenylacetic acid are insulin resistance, oxidative stress, as well as inflammation. So with an elevation in this marker signifying exposure, either discontinue the use of plastics and styrofoam with serving and heating up foods, limit exposures using protective gear, and if you remodeled your home, air it out and use air purification plants and machines. Alpha-hydroxyisobutyric acid is a urinary metabolite of methyl tert butyl ether or MTBE. It's an industrial solvent, but as a gasoline additive to reduce automobile emissions, it has been banned in several countries, including the US, but not all countries. Most recent studies suggest that exposure to MTBE may be linked with diabetes, oxidative damage, autism, methylation defects. The literature links to cancer, neurotoxicity, and reproductive abnormalities and other conditions. It's kind of inconclusive at this moment. So if it is still used in your country, please be cautious. Even if it was used and now is banned, it is very hydrophilic and in our water supply systems. So using water filtration can help reduce exposures. Orotic acid is elevated with ammonia overload from high protein diets and abnormalities with arginine metabolism, plus underlying liver conditions or hepatotoxins like alcohol. So consider increasing arginine foods like soybeans and chickpeas, or use it as a supplement if deficient. But also consider liver detoxification support as the urea cycle occurs in the liver and requires proper functioning. The oxalate markers originate from our diet and regular processes in the body. They are a collection of 3 organic acids, glyceric, glycolic, and oxalic acid, that are metabolic end products of the glyoxylate pathway. There is specific clinical relevance as it relates to oxidative damage and/or metabolic dysfunction, plus catabolic physiology. Glyceric acid stems from the catabolism of the amino acid serine and the metabolism of fructose. So clinical conditions correlated with an elevation in glyceric acid are rheumatoid arthritis, schizophrenia, and bipolar. With an elevation, we look at vitamin B3 and magnesium, which actually are cofactors of the enzymes to support the clearance of this organic acid. Both oxalic acid and glycolic acid come from collagen, either dietary intake or collagen turnover, which is a catabolic process, or reflect the need for vitamin B6 due to poor metabolism of glyoxylate. Glycolic acid is derived in part from oxidative stress in the form of lipid peroxidation and protein glycylation. The majority of this glyoxyl is converted into glycolate, utilizing glutathione as a cofactor. Therefore, lower levels of glutathione may promote more conversion of glyoxyl into glycolic acid. Oxalic acid, the relationship between diet and urinary oxalate level, is complex and dependent on many variables. While the majority of oxalic acid originates from endogenous production, it is estimated that 40% of urinary oxalic acid is derived from the diet. However, these levels are actually largely dependent on the microbiome and the intake of dietary calcium as well. 8-OHDG is a byproduct of oxidative damage to DNA. It has been studied to estimate DNA damage after exposures to carcinogens, including tobacco smoke and heavy metals. So it's positively associated with markers of inflammation and cortisol, which indicates physiological or psychological stress associated with oxidative damage. Elevated levels are seen in several diseases, such as cancer, thyroid disease, cardiovascular disease, and environmental exposures, but also in exercise, but it diminishes with prolonged exercise. The goal is to really minimize exposure or sources of oxidative stress and support the body with antioxidants. So this concludes the review of the Organix profile. For information and literature references, please refer to the Organix support guide and other resources on the website. Again, thank you for your time as well as your attention. Have a wonderful day.